Thank you so much, Roberto. Wonderful job. And we're going to, as we said, get to the questions at the end. So stack those up for us and send them in. And next slide, please. And I'm going to quickly turn this over to Ms. Ledina Picardi, who's been doing a great job in Albania for a long time. Ledina.
Need to unmute.
Hello, can you hear me now?
Yes.
Yeah. Hello, everybody from Tirana. Thank you, Tom. Thank you, Yadin, for inviting me to share our story and the way how we developed our health technology maintenance for medical devices in the public health system with an external contract-based approach. Albania is a small country in Balkan Peninsula in Europe with less than 3 million of people. And as you can see, with a small network of health institutions. Next, please. Regarding the health technology organization structure in the Ministry of Health. Next slide, please. We did not have any clinical engineer to influence the decisions for the health technology management, but following our national policy for management of medical devices, in 2010, a unit for the management of medical devices that later was called Medical Devices and System Units was established. The head of this unit was a biomedical engineer. The unit was responsible for overall supervision of medical devices in public health system and was directly involved in defining priorities, planning the medical devices supply for health facilities, designing regulatory documents for medical devices, preparing technical specifications for the new devices, distributing donation from philanthropic associations based on hospital needs. But for the last 15 years, millions of euros have been invested in new medical devices, urging the need for better management and maintenance. In-house engineers and technicians were unable to repair and maintain the highest level of sophisticated diagnostic technologies due to lack of training programs mainly. But on the other hand, the private companies increased expertise. Manufacturers assigned country authorized distributors for repairs and maintenance, but being a small country, small market, only one company was authorized for each brand. So it was created a monopoly situation, and this provided very high cost service. Next slide, please. So how was the situation before this policy, before 2014? Maintenance of medical devices was done by each hospital. There were no standard procedures, no standard contracts. Some of the spare parts were not included. There were different prices, even for the same devices. We had short-term contracts, and we have gaps between contracts. And the lack of proper maintenance in hospitals caused, of course, poor access. There were long downtimes, increased waiting time, delays when referred to the patient were referred to other healthcare public institutions, increased patient costs when they were referred to private clinics. And At the same time, we had even difficult relationships with the service providers due to service denial, lack of payment caused by poor budgeting, budget planning. And at this point, we designed a new maintenance policy based in the best international practice. We outsourced the high technology diagnostic equipment maintenance service for Linacs, CT scanners, MRI angiographers. It was a full risk, 2 years service contract. It was a long process. It was organized centrally by the Ministry of Health. We started a negotiation process with manufacturer representatives regarding price and condition. And then we opened tender procedures for international participation to have as many as possible. Next slide, please. And we had very positive results. We had access to diagnostic devices and increased availability to local health care diagnostic services. Here is a table with data showing the situation before and after. Next slide, please, when it's shown in a clearer way the positive result of this policy. So, as we will see in the next slide, there are some significant data to show, referring, for example, one of our biggest regional hospitals. The number of CT scan procedures, for example, the previous one, please, from 3,500, for example, at 2013, which was before we applied this policy, increased to more than 6,600 at 2015. Or, for example, downtime for CT scanners from 100 days in 2013 went down to 0 during 2015. And other results were efficient use of public funds, because maintenance costs decreased from around 10–12% to 8% of the purchase price of the device. So we clearly had driven the things in the right direction and with a very good price. Next slide, please. We continue to have investments in health technology. A new block of 7 operating rooms and 120 beds was inaugurated a few weeks ago in the biggest university hospital center in country, which is Mother Teresa Hospital Center. A new pediatric hospital, $30 million, will be ready next year as part of the same university center. And other investments will be soon in health technology in the regional hospitals. The increase of new investments is bringing new challenges in our country because of the lack of clinical engineering staff in the hospitals, due to lack of training and education, higher rate of immigration, mainly young doctors, nurses, engineers, and due to the fact that the doctors, nurses, engineers are moving from public to private facilities due to difference in salaries, limited resources, and very often stress and pressure from directors. But gaining the experience from the implementation of the maintenance policy of the high diagnostic devices, we are applying this policy to other devices as well. And it is just recently called an external maintenance service contracts for a few hundred medical devices, mainly operating rooms, intensive care and imaging devices. This is an ongoing ongoing procedure. Next slide, please. This policy that we are at the moment applying to Mother Teresa Hospital is planned to be extended next year to the regional hospital. But what is new in this policy that we are recently doing? Following the action plan and what we learned so far, we increased contract time from 2 to 4 years, and we improved terms and conditions service contracts. Like, for example, we included the requirement for medical device information system as an important tool for management to register all medical devices according to the model approved by Ministry of Health, to document, to archive inspections, preventive planning, maintenance, and needs for spare parts, for planning the purchase of accessories needed for preventive and corrective maintenance, to calculate costs, to have reports regarding the progress of medical devices. Next slide, please. But how we faced and how we addressed some of the leadership principles and how we use them. For example, innovative culture. The unique role of the clinical engineer was recognized because it had a great contribution from the design to the implementation of the policy. It was the knowledge of the biomedical and clinical engineers that provided the necessary evidence to develop the policy by identification of the preventive and corrective maintenance service needed, by the service rules and national regulation on medical devices. Regarding the evidence-based principle, we provided a lot of evidence from previous years, collecting data from many short contracts, as they used to be, applied from different hospitals. We provided evidence of the problem caused due to lack of proper maintenance. And policymakers allow us to show data and allow us to show evidence, and agreed with us on the steps to follow and the way how to design and implement this policy. And regarding the adaptive decision-making principle, the whole process was very challenging. But after collecting data, we analyzed them. Initially, it was a long list of devices. Then we prioritized them, of course, based on the budget availability. And then we negotiated the terms and conditions. And then we negotiated the price. And we kept going, and we solved at the end all the challenges. Thank you very much for listening.
Thank you, Ledina. Great job, Yadin.